Welcome to this month's Simon Says Expert Series. I'm Barbara Lewis-West. I'm a former radio and television reporter and anchor. I specialized in medicine and health, but most importantly, I am a big fan of Dr. Pat Loehr's, and I am proud to call him a friend. So I want to thank the IU Center for Global Health and AMPATH for their help in promoting today's session. Welcome to those of you who are joining us as part of the AMPATH Fireside Chat. And also thank all of you who submitted questions in advance. They are wonderful. We will try to get to them all today. So for many of you, Dr. Pat Loehrer needs no introduction. He's known around the world as the leading expert in thymoma. He's also an expert in other cancers as well, including colon, pancreas, testicular, and bladder. He's also a scientist. His research on the drug ifosfamide led to its approval by the FDA. And he's also a leader, having served for more than a decade as the director of the Cancer Center and leading it to achieve the prestigious Comprehensive Cancer Center designation from the National Cancer Institute. And he now heads the Center for Global Oncology and Health Equities, the latest chapter in his 15-year quest of improving both cancer care and research in Kenya. In a moment, we'll hear how the work there also resonates here. So Pat, I want to bring you on. Thank you so much for being here today.
Oh, it's my pleasure. What a great honor it has to have a friend interview you. So this will be fun. Look forward to this.
My honor. So the conversation title is Your Unexpected Journey to Global Oncology. So let's start there. How did your journey start?
Well, with respect to the Empath and global oncology, it started with a dinner with Bob Einturns, a photograph, and then meeting a patient. I was trying to recruit a faculty member to join our faculty who did work with Epstein-Barr virus and lymphoma. So I thought I was clever, and I'd invite Bob Einturns, who ran the Empath program, with the thinking that this would be great because EBV is a big cause of Burkitt's lymphoma, and that we would have that discussion and I would seal the deal. During the dinner, Bob pulled out a picture that he always carries with him still to this day of a young boy with the Burkitt's lymphoma and how moving it was. And at the end of the dinner, it was either a rousing success or a failure, but we didn't get the candidate, but it did get me interested in going over to Kenya. So several months later, I did make my first visit there, and when I was rounding on there, it was rounding on the wards there. I just saw extraordinary numbers of patients with advanced cancer. And one woman particularly stuck out to me was a woman who had advanced head and neck cancer. And she was so kind and gentle. And I realized at the end of that trip that I needed to do something to get involved to help. And so that began the journey.
Mm-hmm. So let's talk a little bit before we jump into some of the submitted questions about AMPATH itself. You've been working with AMPATH for over 15 years, developing cancer care in Kenya, training hematologists and oncologists there. So maybe let's start with like an explanation of more about what AMPATH is, and then maybe give us an overview of your work there.
Yeah, you could spend another 3 or 4 hours talking about AMPATH. It's an extraordinary program. Conceived by 4 gentlemen, Bob Einturns, Joe Mamlin, Charlie Kelly, and Dave Van Rieken. They went around the globe in the late 80s looking for a place for a partnership with IU and landed in Eldoret. And this was coincidental with the beginning of a brand new medical school, Moi University School of Medicine, which was the second medical school in Kenya. And it became a partnership initially with education from my version of it, also with care, and exchange students were going back and forth. But a few years later, at the beginning of the 2000s, the pandemic of HIV/AIDS raised its ugly head. And these gentlemen and the Kenyans and they worked with decided they wanted to do something about it. So they created a program called the Academic Model for the Prevention and Treatment of HIV/AIDS. This became the first program in sub-Saharan Africa that took care of food and income and treatment. Incredibly successful. It still is to this day. Because of their success right there, they've moved on to other chronic diseases. And so now it's called the Academic Model, providing access to healthcare. It's now run by Adrian Gardner, who's director of the Centers of Global Health. It is just a marvelous program. I came in about 15 years ago into this with, the program had already been built, but there was little emphasis on cancer and chronic diseases at that time. This was real easy for me to stand on the shoulders of these great giants to help build a program in cancer care.
And we're going to talk a little bit about more about that as we go along. First submitted question. What were some of the most unexpected problems in setting the program up?
Well, yeah, sure. When I first went to Eldoret, it was in terms of oncology. There was a pediatrician who had self-trained with a photocopy of a chapter of an oncology textbook from Kenya, or from Nairobi. That was her own training. Patients came in with cancer, and they might prescribe drugs, but then they would give a prescription. They'd go to the local pharmacist, and whatever drug happened to be available is what they got. Oftentimes they couldn't afford the drugs. The pathology was done by an expatriate from behind the Iron Curtain who made every diagnosis lymphoma, regardless of what cancer it was. And it was really pretty bad. So I, again, with this, we said we have to do something about it. And Alan Rosemarin from University of Massachusetts and I got together, and I came back to Indiana, and I was fortunate to have a very good friend and a colleague who, when I explained this to him, he said, well, how much would it cost to support it for a year? And I made up a number on the spot. I said $300,000. And he said, well, I'll give you 150 now and give me a report in 6 months. So with that, we were then able to start getting drugs and chemotherapy for patients. So over the years, though, as we've grown, and it's really a remarkable program, the obstacles were many things in terms of, one of the things we wanted to do from the very onset is to have radiation there, and it's taken 15 years to get radiation. We had money to build a small bunker, but Joe Mamlin and Bob Eintracht said, no, we want to have a cancer and chronic care center. And so that was going to basically triple the cost of the building. We wanted to get radiation there. And so Peter Johnstone and I went to the IAEA, the International Atomic Energy Agency in Vienna, and they said they would give us a radiation equipment if we had a building and had the faculty to do this. And so we got all of that done. And then they said, no, we can't do it. And so it took many years until basically a year ago, almost this week, is when the radiation equipment finally came. There has been, I think over the years with COVID has also been a problem there, but I think there's been more successes than I think obstacles.
Yeah. Well, let's talk a little bit about funding then, because you started with that, well, 150,000.
Mhm.
Yay. So how are you funded? Where do you find the funding, and how is that going?
Frank Levinson, who's a good colleague of mine, gave us this first startup money. We came up with this idea, and then I pitched it to a number of people. Gary Nicholson, who's with Pfizer, loved this. He was at Eli Lilly, and he was one of our first early supporters for this, and allowed us actually to expand the program, have a faculty member on the ground that was working there, Matt Strother, and later Jody Skiles and Chite Aswara. Behind them came Celgene, Takeda, Bristol Myers, but Lilly has also been a tremendous supporter of our efforts there. The building itself was built with some funding from Craig Brader as the Dean of the School of Medicine, and Peter Johnstone helped out. And then a large donor that Bob secured, who was one of the Lilly heirs, gave a significant amount of money. And then finally, a Kenyan, Mr. Chandaria, gave us some money to help get the building started. It's been a wonderful exercise, and met a lot of wonderful people along the way who are very giving.
So what cancers are most prevalent in Africa? And how does this cancer profile maybe compare to the rest of the world? But let's start there. What cancers are most prevalent in Africa?
Yeah, so just as a backdrop, 70% of the cancers in the world are in the low to middle income countries. And particularly in Africa, there's this unique juxtaposition of infections and cancer. So that there are, Kaposi sarcoma, which is caused with HIV, AIDS, is a viral induced thing by a herpes virus. Epstein-Barr virus causes Burkitt's lymphoma. Hepatitis B, hepatitis C can cause liver cancer. So there's a whole host of a different type of pattern of cancers. In this country, lung cancer is the leading cause of cancer and leading cause of cancer death. And if you take the number 2 and 3 and 4 causes, they still don't match up to what lung cancer does in this country. In Kenya, lung cancer is 9th on the list. It is way lower. Smoking has not been a problem over the years here. But in women, it's cervical cancer and it's breast cancer. In men, it's prostate cancer and it's esophageal cancer.
Okay. So what are the treatments available to Kenya patients? This is an interesting question, a submitted question. Are the treatments available to the Kenya patients comparable to IU?
Mm-hmm. So yes and no. When we started out, there were just a handful of drugs that were available. As we have evolved over the last few years and worked with pharmacies and drug companies, we have drugs, and most of them are generics that we get oftentimes from India. So most of the standard drugs that are available here are also available there. Now, there are, if you will, in the last few years, a lot of new drugs that are out there, biologic agents and very immunologic agents, which are incredibly expensive. And those are not routinely available over there. But the truth of the matter is, if we sit down and reflect on this, and if I had a doctor's bag that required drugs, many of the drugs that we use here in this country in the 1970s, 80s, and 90s, I would put in that doctor's bag. The drugs that we have now, there's exceptions to that. Most of them may add a little bit to longevity of life, but don't necessarily add to survival advantage. A big game changer has been this immuno-oncology, immuno checkpoint inhibitors and immunotherapy, which really does have a much bigger impact on care. But by and large, we can take care of a lot of the standard cancers over there with the drugs that we have available today.
Okay, and what are the outcomes? That's the second part of the question.
Yeah, the outcomes are, we're building on them. I guess one striking statistic is that childhood cancer in the United States has about a 90% cure rate. It's horrible to get cancer in kids, but they do incredibly well. If you have the misfortune of being born in Africa or sub-Saharan Africa, the cure rate is 10%. And so it is vastly different. Now, a lot of that has to do with the availability of drugs, but also access to care. There's and we probably will touch on that a little bit later, but with the drugs being administered in a timely fashion, the cure rate should be as good as they are here. What we have seen in the last few years, our cure rate for Burkitt's lymphoma has exceeded 50%, which is terrific compared to the way it was even when Bob was holding that picture of the young boy.
Okay, well, we will get to access to care and training future oncologists and hematologists in a second. Here's another submitted question. Are there any lessons you learned from your Kenyan colleagues that are benefiting Hoosiers? So taking what you've learned there or what's being done there and applying it here.
Yeah, it's interesting. So in Kenya, we think of them having uniquely different problems. And in many ways, yes, but in many ways they don't. So, one of the problems is access to care. And maybe the other problem is misinformation. It may be, equipment and supply and personnel. All those things actually are affecting us here in this country. And it's particularly been uncovered in the COVID pandemic. But I think one of the unique things that they've done there is use community healthcare workers, because there's a shortage of nurses and doctors over there, and community healthcare workers can go home to home and see patients. So this is something actually Deb Litzelman has picked up here and is using community healthcare workers in the underserved areas of Indianapolis and up in the rural parts of, I think, Delaware County, in which community healthcare workers are going home to home. And particularly for reluctant patients and for shut-ins, it's been really working well. We have a Project ECHO that Tyler Severance, who's one of our pediatric residents, helped spearhead. ECHO is a program that came out of New Mexico that works with communities around the state. So in Kenya, there are multiple regional rural places in which they now have telemedicine, if you will, on a regular basis, and problems are presented, tumor boards are presented, but oftentimes actually what happens is that we find out solutions to problems that are shared among all the different people in Kenya, among each other, that help each other out. This Project Echo is also now being done here in Indianapolis. And so those are just a couple examples.
Okay, all right. Where am I here? Oh, good. So what kind of family and social network support is available for cancer patients in Kenya? And how does that affect outcomes? Again, you can apply that to what's happening here.
Yeah, so my first visit to Kenya in the hospital, I ran into a little place in the hospital that Sarah Jo Mamlin had set up for abandoned orphans, and they were being there, and they would just cuddle with them and take care of them, and it was just a wonderful experience for them. They have since then, actually, we have created a Shoes for Africa pediatric hospital, and there's now going to be a similar pediatric oncology hospital that's being there. I think a very unique thing they've done is it's not just medicine. This is one of the early lessons from the AMPATH program. Patients who have disease also have problems with income and food. And so in the early aspects of the AMPATH program, they had farms in which they let the patients and their family members work on that generated food that would be sold back to the hospital. They had an Imani workshop that took many of the widows there would make products that they would then sell, so they would have income from themselves and also give purpose in life. More recently, they've created these things called GISIs, which are group integrated savings for empowerment programs. So these GISIs are basically done with typically women. 10 to 20 women get together in a group, and it's a microfinancing where they give loans to each other. I think there's over 400 of them now scattered throughout Kenya. And so if they're having healthcare problems, they may get together and take out a loan. They pay it back. The acute part of the program, which I really loved, is that if you go to these group meetings, if you are late, you have to tithe. So if you come in late to a meeting, you have to put money into the bank there. And so everyone starts on time. I wish we had that here. I think there'd be a lot of meetings that would start on time and end on time here. Well, and then the last little point on that too is actually a project that Terry Vick has started with Burkitt's lymphoma. We recognize that many patients would come in with a diagnosis, get treated, and then they would fall off the map. And so with a grant that we got from the NCI, a supplement we used for improving access to care, we give the patients a small stipend to help to pay for transportation for these kids and their parents, and to help pay for some food. And with it, as I mentioned before, our cure rate has gone from 10% to around 50 to 60% now for these people, because they're now coming in routinely for their care rather than skipping treatments.
I remember when I went, this was a long time ago, the first and unfortunately only time that I visited was like 14 years ago. The Mother and Baby Hospital was just being built. And you're right, the resourcefulness, whether it was treatment or just helping, the jobs or the food. It was amazing how much can be done with just that kind of coming from a place of just kindness and compassion and resourcefulness. I think that's what touched me the most. And it sounds like that is still continuing. You look around with your program and see what the next need is, and you find a way to fulfill it, or see what the next treatment is and how to do that economically.
Mm-hmm. Absolutely. Absolutely.
Let's see, another submitted question. What can be done to open up radiotherapy, cancer diseases research studies? I guess for that matter, chemotherapy could be included in that. So when we're talking about opening up new ways to do research studies, the person who wrote the question is particularly interested in radiotherapy.
Yeah. So as I mentioned before, one of the missions I had was to get radiation therapy in place there, and fortunately, this has now been opened up. And I was in Eldoret with Terry in June of this year, and was completely flabbergasted that they've already begun construction on a second bunker for radiation, and the CEO is already has the commitment for another radiotherapy machine there, which I guess once you have the first one, it makes it so much easier to get the next one. So we do now have radiation therapy available. We have chemotherapy available, and we have trained radiation oncologists and trained medical oncologists that are there. In order to do clinical trials, there's an infrastructure that needs to be created. You need to have institutional regulatory commissions, in which they have on board there. You need to have, in some cases, for translational research equipment, like freezers to store equipment, we have those on board. We need data managers and research nurses, and we have those study by study. But what I would love to have is a more formalized cancer research program that has the capacity to expand as trials come in. We have done it. We have done several trials, but it has been a little bit limited. And I think what we need to be doing, I think there's been some hesitancy, I think, from the NCI to get involved with clinical trials in sub-Saharan Africa. And if you just actually take a measurement of trials, I have to give a talk in another couple of months. There's something around the world like 44 million clinical trials that are being done, according to clinicaltrials.gov. Only 991 of them are in Africa, and that means it's like 1.5% of all the clinical trials. And actually, if you hone down, there's only a handful of clinical trials. So I think this is an avenue of growth. I really, in my vision, this is what we need to do to really change the face of cancer in Kenya. Let me put another spin on it. In this country, it was in the 1960s and 70s that we started doing clinical trials. And back then, drugs were just starting to emerge. And Larry Einhorn, who came up with the cure for testis cancer, did an institutional trial. It was then done in a cooperative group among a number of other centers. And the cure rate for testis cancer went from 5% to 95% because of his work and his leadership, but because of these clinical trials. We need to do the same thing in sub-Saharan Africa, where we get clinical trials in which all the communities can do it. There's a protocol they follow, a formula in terms of how you treat patients. It will raise, I think, the quality of care, but it also will inform us about the uniqueness about patients in Africa compared to the rest of the world. So we look forward to that. That's really a big part of my mission moving forward.
Yeah, and you've said in previous interviews that the success of any global program really comes down to people. So training physicians and nurses in cancer care. So what's needed now in Kenya in terms of training and personnel?
Yeah, we have more people here at IU doing myeloma as treatment physicians than we have for all of the oncologists that are there in Kenya. There's a drastic shortage. I think they estimated over 2 million physicians are needed globally to take care of the number of patients there. If you think about in the United States, we have something like 25 healthcare professionals for 1,000 people. In Africa, it's about 2. And so we do need to train more oncologists, more nurses, even the healthcare workers. Cancer is a very complex disease. It's not, I don't want to denigrate any other specialties, but it's not just like popping a pill. These guys need surgery. They may need radiation. They need chemotherapy, which sometimes can put you close to the edge of death because of the toxicity of it. And this integration of all of these specialties together require very unique care. It requires some judgment, and it requires training. So what I would hope to do is again, I think what we've done in AMPATH is to create the beginnings of an AMPATH Oncology Institute that will have formalized training period for the Kenyans, so they can get trained there in Africa rather than having them come over here to get training and hope that they'll go back home.
Okay. And then also we talked about surgery, so oncology surgery. I know that you have some efforts around that. Tell us a little bit about that.
Yeah, we were fortunate. Gary Dunnington, who just stepped down as chair of surgery, really put his skin in the game in terms of supporting research or surgery over there. Before that, Dave Matthews had gone over there on his own. Gary Dunnington has embedded a surgeon there for the last 6 to 10 years, in which they spend 2 or 3 years in a block there working with them. So again, we need to develop, as surgical oncology goes, we want to develop a surgical oncology fellowship training program to go into the specifics of training there. But it is, we as medical oncologists, we think that we're the center of the world. It's not true. We're just part of a team of people that are involved with cancer care, and that includes gynecology oncologists, in which we have a training program, and we have pediatric oncology, in which we now have a training program. We have 2 graduates now. We will have a medical oncology training program there. But this is, we've got to have, we need the knowledge embedded in them, and we need to have them and have the collective wisdom to make the right decisions for their patients.
Okay, a little follow-up, because we were talking about the need for more research studies. So would this program, where you're really working towards getting more people trained and more people on the ground in Kenya, would that, is the research, the efforts that need to be made in research kind of a parallel track, or is it really combined?
Yeah, AMPATH has this tagline, leading with care. And that's what makes this unique compared to most other global programs around the country, or even around in Europe. Most of the time they lead with research, in which they have a partner in research and another partner here, and they do it. Leading with care is a challenge, and it's a charge to make sure that what we're doing first and foremost is taking care of the patients. So everything beyond that goes into that. So as we're doing research, it ought to be research that's impactful on the care of the patient. So if we're going to treat Burkitt's lymphoma, for example, we want to have chemotherapy plus rituximab. I think we can also get some genomics to understand the biology of the tumor. But it is not, in my mind, I don't consider our research the kind we want to do is where we go over there, collect tissue samples, bring it back to North America, do analysis, write a paper. Education also is informed to leading with care. So we want to educate the next generation of clinicians and clinician researchers. So all of this ties together, but it is, from Indiana University's point of view, research is important because we get grants and that gives us prestige. So this is a pillar that's important to us, but we want to have that formula to make sure that we're having impactful research.
Okay, and here's a question that just came over our chat. What efforts is the Kenya Oncology Program doing to prevent cancers associated with viruses, for example, HIV, HPV, and Hep C?
Yeah, so that's a really, really good question. So in Kenya, as I just mentioned a few minutes ago, cervical cancer is the leading cause of cancer and cancer death among women. Cervical cancer could be eradicated from the face of the earth if all the women underwent HPV vaccination. Many head and neck cancers, even in boys, can be, many head and neck cancers could be prevented if we're given the vaccine to boys too. We have a program. Merck just gave us enough vaccine to vaccinate 1,000 young kids between ages 5 and 15 with the new HPV vaccination. The government of Kenya now has approved this HPV vaccination, but the next step is getting the rollout. And this is where, again, AMPATH and this population health will help us figure out a way to roll out these vaccines. They have the same problems, though, there that we see here in terms of vaccine hesitancy. And so this education, working with community groups to try to overcome some of the stigma or the misinformation about the vaccines are important. But I think we do have a huge opportunity with vaccines to really make a huge impact on the prevention of cancer.
Okay. Well, let's keep going with that topic, but let's bring COVID in, which you alluded to in your last comment. So COVID has shown a harsh light on where we are with global public health and the spread of infectious disease. Are there any lessons or studies or areas of interest for global hematologists or oncologists in all of this?
Yeah, a couple of things. One is, the AMPATH program is uniquely suited to take care with pandemics. I mean, they were created to deal with the HIV pandemic. It's no small coincidence that Adrian Gardner, who is the head of the Centers of Global Health and leads AMPATH, was chosen by the dean to help with the rollout of vaccines for the state of Indiana. And so how we do the COVID vaccination and how we get it around the state of Indiana is well informed by the work that we've done, the work we have done in Kenya. They suffer tremendously with COVID, and they had a number of their faculty that have died over there, and healthcare workers. So it is a serious illness there. They were, if you will, and most of the LMICs were low on the threshold of getting these vaccines. And so we need to get those things rolled out. I just got an email from a friend of mine who wanted to know if she should get her 4th shot for her vaccination here. And unfortunately, many people in Kenya haven't gotten their 1st shot. This is what we have learned here in this country is about prevention now. We believe with the COVID, it's better to prevent somebody than to treat them when they're on a respirator with monoclonals. I think the same lesson goes to, as we were talking about a minute ago, with vaccines and cancer. If we could prevent cancer, rather than just wait to treat them, we can save hundreds of thousands, millions of dollars on many patients in terms of their treatment if we could just prevent it. And so this, I think, is a lesson learned from COVID.
What do you say to people who say we have our problems here in Indiana? We have our problems here in the United States. Why should we get involved in work across the world?
Yeah, that's a terrific question. And again, we can take it back to COVID. COVID began across the world. And what we recognize now is that we are all on this small pale blue dot together, and that there is no problem that is in one part of the world that doesn't affect all of us. As a clinician, and I think all of us who have been involved with this program in Kenya, when you take the time to go over there, and Barb, you were over there, and when you're over, you suddenly see the world a little differently, a lot differently in many cases there. What we worry about here, I'm here on Monday night until 8 or 8:30 dictating my notes to make sure that I've gotten enough RVUs to help pay for things. We worry about talking to insurance companies to make things are cost. When you go to Kenya, you actually just worry about, you see patients who have these cancers, and you can actually do some things right away and make a difference. And so it is many people who have done this, it actually revitalizes them. I think when you go there, we have patients who complain that they have to share a room with another patient. You go there to their hospital wards in which they have 6 or 8 beds in a ward, and yet there are 2 people in each bed, so it's a cot. So if you're complaining about having a room with another person, just imagine what it's like over there. So we end up, we recognize that there are the small stuff that we have to do. In this, what I hope to do too is, again, in this country, things have gotten out of hand financially. The cost of the drugs, the cost of doing research has gotten out of hand. And I think there's an opportunity in Kenya to do it the right way. We can get involved with prevention and screening earlier. We can get involved with doing research much more simply without all the extraneous stuff, and get the answers to things. And I think from that, we're going to learn lessons. And this is a laboratory in which the Kenyans, in this case, are going to inform us on how we can do things a lot simpler and easier than the complexities of the things that we do.
Is that part of your pitch to medical students and residents and fellows to go over and go over to Kenya and start their journey and global medicine?
I think so. I was in college. I went down to Bradenton, Florida, and that was the first time I went on vacation out. These kids today go all over the world, and global health is something that's in their DNA. And so about 80% of students today want to do something in global health. And so this program at Indiana University is totally unique. And it does give the opportunity for students and residents to get over there to get a flavor of what's going on. And I think that that experience stays with them the rest of their lives.
Let's switch gears a little bit here, and then for another question that was submitted. So there's actually several about nutrition and cancer and oncology. So let's start with this one. How does nutrition figure into cancer, including global oncology?
Well, this every day in clinic, patients will ask me about this, and this is a field that still needs to be delved into a lot more deeply. It is true from epidemiologic studies that certain diets are associated with different kinds of cancer. So, for example, in Asia, esophageal cancer is very common. In the United States, it was less common. In Hawaii, it was intermediate. Gastric cancer was the most common cause of cancer in the early 1900s, and it has just plummeted down. It's starting to rise again. But maybe associated, a lot of the stuff may be associated with what we ingest and what we eat. I should mention that we've never had a time in the history of humanity in which the cure rate for cancer is so good as it is today. But nutrition also may play a part in the drugs that we give. And there is some emerging data that what we call the microbiome, so the bacteria that make up your gut, there are different microbiomes that we all have, and that the different microbiomes may affect how different agents, particularly immunotherapy, works in different people. And so there are some experiments even doing fecal transplants in order to change the microbiome. I think we're going to get smarter about this as time goes on. Now, the difference in Kenya and here, by and large, is that the Kenyans typically are a lot more svelte than we are here in the United States. But that's changing. Obesity is also becoming a problem over there. But I do think there are some opportunities, although it would be expensive, to do some studies looking at the microbiome of our Kenyan and the African patients and compare it to these people over here and how they respond to therapy and how their cancers respond.
And there was always, I remember 14 years ago now, but and I'm sure it's still the same, is the food insecurity in Kenya. The need to write the prescription for food was part of the everyday because of the H. And then that was back when, HIV. So you can't give HIV drugs to a malnourished person and expect it to work. Is it the same? Are you finding for what you can do for them for your different cancers, cervical cancer and the like?
Yeah, so I'm not, our cancer program isn't as intimately involved with the food program as it probably should be. I think there's an opportunity there, but I do, I do think that there's a link between nutrition in terms of making sure patients are at least getting the minimal amount of calories that they can get in a day, particularly these malnourished patients. The income, because we've got to make sure that we don't make them impoverished even more than they are. And in this country, one of the most common causes of bankruptcy is coming down with cancer and having treatment. And we've got to, in this country, have to also deal with the fact of this financial toxicity that we're imposing on patients.
Another question just came in through the chat. Are there any opportunities?
When are you going to quit? When are you going to be quiet? Is that the question?
What you're going to like this question.
Okay.
Are there any opportunities for donating to these Kenya initiatives?
Oh, I love that one. So
I didn't write that one.
Oh, I love that one. Yeah, there absolutely are. So this is work that's well done. The investment, there's a huge return on investment. So we are so grateful for people who consider donating, and there are different capacities. So, but Megan Miller, who works for AMPATH, Amber Klepfer-Sensini, who's with the Cancer Center, both of these people would be more than willing to help or me. Just give me a call anytime and I'll be happy to help steer that in there. But we have not gotten this far without philanthropy, and we can go so much farther.
Okay. Well, let's start to wrap this up because we have only about 5 more minutes. And if anybody has any questions, please put them in the chat now so we sure we get them in before we stop. So what thought, idea, question, or message would you really like us to take away from today's conversation?
Well, reflecting on this a bit, when I went in, I was thinking about this morning. It was 50 years ago when I decided I want to go into medicine. I was in high school at the time, and I've been a doctor now for a little bit over 40 years. If you ask just about every medical student why they want to go into medicine, they all say the same thing. They want to make a difference. This field of medicine is a vocation. It's a calling that pulls all us in. And many times, actually, this vocation competes with my other vocation of marriage. And I really want to have a shout out to Debbie for all the support she's given me over the years to allow me to do this exploration there. But in this profession, the majesty of it is that we get to meet some extraordinary people One of the people I didn't mention was Julie McGowan, who runs a hospice that's in Eldoret. She works with Ken Cornetta, one of our faculty people. Ken is another extraordinary person who was head of medical genetics for our bone marrow transplant program, and for some godforsaken reason decided he wanted to give that all up to do a fellowship in palliative care. So he did a fellowship in palliative care. So here you are. I got to say, if you want to figure out how to lose money, it's to become a palliative care doctor. But Ken is over in Kenya right now. He's completely devoted to this. But this has been an opportunity for me to meet so many extraordinary people along, not only here and throughout the country, throughout the world. And so for me, as I think about this, I just thought about this a few minutes ago. Most people go into medicine to make a difference, but it's taken me 40 years to realize that it was medicine that has made a difference for me, that has changed me. It has made my difference, my life better, more rich. And I really enjoy the fact that I've had so many different paths and journeys and met so many people here. But of all the things that I've done, working with my colleagues in Kenya, doing the AMPATH program, that's really been one of the most rewarding things for me personally. And so, yeah, thank you for the questions, and thank you for allowing me to ramble a little bit today.
No, that was great. And I was just thinking one last quick question about like telehealth, because we were talking about, going over, and there has been, there are restrictions on travel. So how is telehealth playing a role, do you feel, in global oncology and what you do with the program in Kenya?
Yeah, so it has played a role. And so we can do remote tumor boards this way. And we not only within Kenya, but also with North America and Kenya. And we expect that to even expand even further as we do our fellowship training program. But it's also here, it's become a way of life here in the States. And even with these conferences, it's not unusual now to have these teleconferences here. And so this will change how we affect care and how we deliver care and communicate with people. So it's a good time to have a crisis, is when we have the ability to be able to see people face to face on these kinds of means.
Pat, thank you so much. It's always so good to get your insights and hear from you. And thank you for all you do here and in Kenya.
My pleasure. Good to see you again, Barb.
See you. And thank you everyone for joining us. Next month, Simon Says session will focus on the impact of physical therapy on the quality of life for cancer survivors. The details will be on your screen for that. So I hope you take advantage of that next month. And this will of course be available. It's recorded, so you'll get a link to it. And I hope you share it with anybody who would be interested.